call today for this e-experience exchange program. And for this event, we are honored to have collaborated with the Physician Forum of India. And on behalf of Physician Forum of India, we have Dr. Chauhan here as well today. To briefly introduce, before I hand over to Dr. Chauhan, I would like to briefly introduce the moderator and the speaker for the event today. The topic today is lipid management after a PCI and the role of PCSK9 inhibitors. Our moderator and speaker for today is Dr. Viveka Kumar. He is the Principal Director of Cardiac Sciences and Chief of Cath Lab, Panmax Healthcare. He has several awards and qualifications to his name. In lieu of time, we'll keep the introduction short. Next, we have Dr. Ripen Gupta. He is the Director and Unit Head of Cardiac Sciences for Cardiology at Max Healthcare. Again, a very accomplished professional. And then we have Mr. Sameer Kubba, who is Associate Director Cardiology, Max Healthcare. And as you can see, he has several degrees associated with him. With that short introduction, just to honor the time, I would like to end my presentation and would like to request Dr. Chauhan to introduce himself and highlight the role of Physician Forum of India.
So, friends, I welcome all of you to this important presentation on PCSK9 inhibitors. I believe Dr. Viveka Kumar wants to introduce the topic, but I am in guest appearance, as you can understand that I have to introduce myself. So my name is Sushil Chauhan. I am Vice President of Physician Forum of India. I am basically a physician. I graduated from Maulana Azad in 1983 and did my post-graduation from Sarjan Hospital in 1988. I did my residency and spent some time in Gulf for about 5 years, and since 1995 I am in active practice in South Delhi, and my interest number one is academics. I have been having regular webinars under the guidance of our patron Dr. S. Mathur sir and President Dr. P.K. Gupta sir, whose vision it was to have regular webinars to upgrade our GP friends, our physician friends, and friends across the specialty, so that they have some deep into the field of medicine and they can understand what the colleagues in the field are doing. We've been active in the field of webinars, 671 regular physical webinars, physical meetings, till we stopped meeting physically in the March of 2020. Since 2007 and 671 regular business CMEs, and since then we've been having regular webinars. Today's webinar should have been on our day for the academics. There was an arranged Dr. Viveka sir and Dr. Reddy's lab. We had to do it on a Friday. I am extremely grateful to all of you to have come on board. Vidya introduced me as one from the forum. There are 38 from the forum at this point in time, and I welcome all of you to this important webinar, and I am extremely grateful to you for your presence. As Dr. Viveka will take little more time, I believe, to be on board, let's have the first presentation from Dr. Sameer Kubba sir. And as you understand, the topic is on PCSK9 inhibitors, the new kid on the block for aggressive lipid lowering.
But what we are going to talk today is that the risk in CAD patients and acute coronary syndrome patients which persist despite a high dose of statin therapy. And we are going to discuss that, which is more common, but nevertheless, the point which I wanted to make is you should screen for FH in some of your patients in whom you have these criteria. Now, if you look at data, Dr. Chauhan was mentioning that many of the patients will be statin intolerant or may have statin-associated muscle symptoms, and they may not be doing that very well, so you may need to change over to injectable therapy. But more importantly, at times the patient would be on a higher moderate intensity statin, but would not have the LDL goal achieved. And what is the LDL goal which we are going to discuss today is, now if you look at FLUID 2022, the IDEAL trial and the THG trial, despite a moderate intensity statin, there was a residual CV event risk between 10% to 26%. And high intensity, it was somewhere between 8 to 23%. So we are very, very clear that even in trials and meta-analysis, when we are using statins in a high dose or a moderate dose, still there is a category of patients who still continues to have events despite achieving an LDL of goal. So what do we do with those kind of patients? Now, before going into that, you must understand that if you have a combination of coronary artery disease and diabetes, your risk increases phenomenally once your LDL goes beyond 80 or 90. And you should see in this green graph, see how the risk is suddenly increasing beyond an LDL of 90 in a patient who has CVD and diabetes versus a patient who has no diabetes and no CVD. And we know that diabetes is now considered to be a coronary artery disease, this equivalent. Any patient with diabetes who is more than 40 years of age should at least receive a moderate intensity statin. If you look at the problem of statins, not only intolerance, not only statin-associated muscle symptoms, there is also an inter-individual variation with regards to LDL reduction. So some patients may have a good LDL reduction, some patients may not have it, and what we see in trials is the median LDL value, but we do not see the inter-individual variation. And this is a meta-analysis of about 36,000 patients, which actually shows that despite the all kinds of statins which we use most commonly, atorva and rosuvastatin in our part of the planet, we still will have inter-individual variation, and only 40% of the individuals achieve an LDL below 70. And this is what it actually showed, that if you are able to achieve an LDL of less than 70 and possibly less than 55, the risk of having a recurrent event phenomenally reduces. And now we have drugs which we can achieve that kind of an ultra low LDL, especially in patients who are very high risk. And the kind of patient which I discussed in the slide initially, and any patient who has had an event automatically becomes a very high risk patient. And we are comfortable at times with an LDL of 80 or 90, but we should actually move from that inertia and try to achieve a lower LDL by whatever means. I'm not saying give PCSK9 inhibitor to each and every patient, but try and use a high-dose statin, ezetimibe, diet and lifestyle modification. And if you're not able to achieve goal, try and use PCSK9 inhibitors. Now, this is another data from the DICES2 which actually shows that despite whatever you do, patients with CAD and patients with ACS, many of the patients, about a significant proportion of patients, do not achieve an LDL of less than 70. And this is very, very common. It's not uncommon. Here comes the role of PCSK9 inhibitors, and what we know about these drugs is that they actually modify the PCSK9 LDL receptor interaction in a favorable fashion so that you have more of LDL receptor at the surface of the hepatocyte, which leads to a lower plasma LDL cholesterol, because PCSK9 inhibitors competitively actually interact with the PCSK9 molecule present in the plasma. Now, this is the 4-year trial which was supposed to be discussed in detail initially, but I will just go into very brief aspects of this trial. So, our trial which was done in high-risk patients, absolutely stable patients. Now, the word stable is actually a misnomer, because we use this word stable and we feel that the patient is stable, when actually that is not the case. And we understand that despite whatever we do for them, we are seeing a lot of recurrent events, and hardly do I see a patient with a clean coronary artery nowadays. Something has happened, and we see multivessel disease more frequently as a norm rather than an exception. So the 4-year actually looked at about 28,000 high-risk patients with established CV disease who have prior MI, stroke, or symptomatic peripheral artery disease, and their LDL cholesterol was reduced by about 60%. So if you look at the mean LDL, it was 92. So something which is already low, and they reached up to a median of about 30. And what they found was that patients had a significant reduction in cardiovascular events, and all these patients might be on statin therapy. And what they found was not only it was efficacious, but it was safe and well tolerated. And this is also corroborated by the Evenol data that you can actually reduce your LDL to even to the tune of about 20 in patients who actually have very, very high risk. Somebody who is diabetic, somebody who has a multivessel disease, somebody who has a recurrent MI disease happening once in every 2-3 years, somebody who has a multivessel disease. So choose your high-risk patient and try to give them the benefit of this drug wherever possible. And this actually shows that the lower the LDL, the better it is. And it's a monotonic relationship with the LDL cholesterol, which we achieve with PCSK9 inhibitors. And even to the tune of 20 or less than 20, you have no safety concern. And in fact, some of the patients reached an LDL of even less than 10. And this is data over a median of 2.2 years. So definitely we need larger data. But we have seen for so many years with statin trials and also with now PCSK9 trials that if you achieve an ultra low level of LDL, you usually do not have significant side effects, especially for those patients who require this kind of LDL lowering therapy, the very high-risk patients. The take-home messages are we need to concentrate on LDL cholesterol as the primary target for the treatment of atherosclerosis. We have looked at triglycerides, we have looked at HDL, we have looked at non-HDL. All these are important for risk analysis and treatment, but if you look at the hard endpoint, it is only the LDL cholesterol reduction which translates into clinical benefit. And high-dose statins in clinical trials reflect a mean reduction in the LDL, which I was talking about, and there are large inter-individual responses to statins. So choose your patient individually, and if you have larger reduction in LDL cholesterol, you are lowering the risk. So for we cardiologists, any patient who has had a CAD or a stent or an MI automatically qualifies into a very high-risk category, wherein the target for the LDL becomes less than 55 according to the ESC guidelines and less than 70 according to the ACC&I guidelines. And we at the Lipid Association of India now even target to less than 40 because we have seen our patients are younger and they have more severe disease. And Korea, which I have discussed briefly, actually looked at the high-dose intensity statin, which actually was, and evolocumab was added over it. And what we found in this trial was there was a significant mortality benefit and also lowering the LDL to significantly low levels, even to the tune of less than 10, was safe and well tolerated. So, and especially if you're a patient who's had a recent MI, recurrent MI, multivessel disease, and peripheral artery disease, when you are discharging them, have a clean look at their LDL levels, possibly start them on ezetimibe also, but keep it in mind this drug, which actually can be of benefit to some patients who are very, very high risk. The only downside is the cost, but that I think in years to come would become easier for the patients to achieve. And just to end it, let me show you the lipid profile of patients who actually received the injection evolocumab, and you look at that LDL, which is an LDL of 14 here, and this kind of an LDL cannot be achieved with high-dose statin and ezetimibe therapy. And this patient actually had some financial issues, and intermittently she was stopping the injection, and you see how the LDL goes up to 142 when she stops the injection. And now she has got this payment from the insurance, so she is taking it on a regular basis. So these are practical aspects which I wanted to discuss, that at times your patient may take some injections, may not be able to take it again, but if you are able to achieve a phenomenal LDL reduction, you can do a lot of benefit to this patient by giving this kind of an injectable. Thank you very much.
Thank you, Dr. Sameer, for a wonderful presentation, sir. I would like you to stay till the end of the presentation. We will have questions and answers in the end. So please stay. I think Dr. Viveka sir is on board now. Sir, you are there?
Yeah, I'm there. So thank you very much.
Very nice. No problem, sir. Dr. Viveka was supposed to be the opening batsman, but time and again he has shown that he is one of the best middle order batsmen India has right now. And sir will start his presentation now, and that is how I use PCSK inhibitors in my practice. Over to you, sir. Sir has already been introduced by Vidya.
So good evening, friends, and this evening rain was with the day in reaching home, and I wanted to be at home to meet you. So it was a very good presentation by Dr. Kubba that the call has set rolling, and if you see, the culprit is the LDL, and we need to control it. It is hard. So let me share my experience. So how I use PCSK9 inhibitors in my practice. So you see the efficacy of PCSK9 that has been shown by Dr. Sameer Kubba in this one of the lectures. So in acute coronary syndrome, it has got most effective data. So SSDA DVD with PSC 2019 guideline, and that shows that the patients who have a very high risk, their documented case CSC includes previous acute myelin infarction, stable angina, chronic vasculitis. So all those patients who have coronary event or stroke or PCI or peripheral vascular disease means that the evidence of affecting the atherosclerotic disease in anywhere in the vascular tree is high risk and very high risk, and then the patients who are at a high risk, people who are markedly elevated risk factors, in particular the total cholesterol, that is, and the LDL cholesterol again more than 150, more than 190 days, and then those who have got risk lower. So we need to go by these guidelines. So either by the CSP guideline or ACC guideline, we can classify our patient very high risk, moderate risk, and low risk. So those who are at a high risk and very high risk, there the intensity of statin therapy and the aggression of lowering the LDL cholesterol is very, very important. So in no level of LDL below which benefit diseases or harms others has been defined, and there is no known adverse effect of very low LDL. So I also had many patients where, after a couple of months or 3 months therapy, we have seen that the LDL level has gone as low as 10, and the patient got panicked and called me that, my LDL has gone low. But if you look at the guideline data in patients who have got very high risk primary or secondary prevention, more than 50% LDL reduction from the baseline and LDL cholesterol less than 55 milligrams per deciliter is the desired goal. Then, if you look at the current statin therapy, it's very unlikely, as Sameer has also echoed the same sentiment, that it's very unlikely that we would achieve that kind of low values of LDL cholesterol and, with that kind of rapid intensity and without much of side effects, because you can go total high dose, and then we'll discuss also that there are many times where you need to decrease or de-escalate with statin therapy because of the side effects and all, and patients do not tolerate. In those situations, we need to be looking at it. And in high intensity risk patients also, more than 50% LDL reduction from baseline is required. The Sameer has rightly said that in lower risk we can be in moderate in decreasing the lipid value. So 3 key concepts of lipid lowering strategies to reduce the cardiovascular disease in 2019 PCSK guidelines. If you start early, so if you start early, less lipid exposure, it's like a bad environment exposure there. So if you prevent it, the problem will be less created. And then to start early, treat more aggressively. So from desirable LDL elimination in the blood is very, very apt thing to do, and then use a combination therapy. What does it mean? It means that the LDL cholesterol lowering, we should combine everything what we have in our hands. So, maximum possible tolerable dose of statin, ezetimibe, and PCSK9 because you see risk of, atherosclerosis. So early intervention is important to reduce the risk of another acute coronary syndrome. This is again the data from 2019 PSC guidelines. So there are, lipid lowering therapies to be initiated as soon as possible to increase the patient adherence after the discharge, and determine if the patient goal has been achieved, check for the safety issue and adapt to the treatment regime as needed. So the recommended lipid intervention time for patients with acute coronary syndrome is day 1 admission for ACS and lipid profile testing. Then you need day 1 and 4 to initiate the high intensity statin therapy, or if already taking maximum tolerated statin therapy and not at LDL cholesterol goals, consider adding PCSK9 inhibitor. Week 4 to 6 re-evaluation of the lipid levels, and if LDL level is not at least maximally tolerated dose, then in week 8 to 12 you can consider adding the PCSK9 inhibitor. The goal is not achieved on maximally tolerated statin plus systemide. Then why is there an urgency to lower the LDL cholesterol even after an ACS event? So nearly 1 in 5 patients will have a recurrent cardiovascular event during the first year post-myocardial infarction. You can clearly see this data shows that almost 1/5 of the patients will have within 1 year some disease evidence, and this data is for nearly 100,000 patients that hospitalized with acute myocardial infarction. Retrospective observational cohort study of British National Registry for all patients with a prior MI. Median age was 72 years in MI population, and mean duration was up to 2.5 years. There also ischemic risks are rated in the very early phase of post-myocardial infarction. So you can see again they were average daily ischemic and bleeding rate within first year after primary PCI study. You can clearly see that there is a ischemic risk is there in these patients. So evolocumab rapidly reduces the LDL cholesterol in just 24 hours in acute coronary syndrome patients during the hospitalization. And effect of evolocumab on atherogenic glycoproteins during the peri and early post-infarction period is also there. So, this again data clearly shows that these patients where if you have good LDL cholesterol that goes down, and the glycoprotein EGA also goes down significantly. So how should we communicate the benefit of PCSK9 to the patient? So will the patient, because most of the time it's been seen that it's a costly molecule, but I always say it's a cost-effective molecule. If you can save the kidney matter infarction, it can decrease the progression of atherosclerotic disease, and obviously it is very, very cost-effective. So the LDL cholesterol is the building block of atherosclerosis, because you would know that the following the acute coronary syndrome, the patient has high risk of subsequent ischemic events, and each recurrent episode is associated with increased mortality and heightened predisposition to a symbolic event may persist for years together. And the goal is to optimal medical management and risk factor control that targets their atherosclerotic burden as a whole. So this is the cascade of what we call for inflammation leading to platelet aggregation and the coagulation causing mitral infarction. So lipid is one of the most critical modifiable cardiovascular risk factors for acute mitral infarction. And when you look at the modifiable risk factors, when you compare right from alcohol to hypertension, exercise, smoking, and the lipids, you can clearly see this is the population at risk where the maximum modifiable risk can be to the lipids as well. The changes in atherosclerotic burden have been demonstrated with lipid LDL lowering, and the median change in the average treatment of LDL cholesterol in severe coronary IVOS trials have also seen the progression studies right from the statin data to the illustrate data and reversal data, which was all of them established study also showed that it is directly proportional to whatever the arrest of the progression or even some amount of regression was with the intensity of the decrease in LDL level. So early intensive lipid lowering in the case of acute coronary syndrome, Glavo's study primary endpoint also showed that statin plus evolocumab versus statin monotherapy, you can see that the statistically significant change was there when the statin plus evolocumab was given compared to the statin monotherapy was given. So evolocumab established the vulnerable coronary plaque and reduces their size. So vulnerability of the plaque also gets stabilized like statin. With the evolocumab also the similar kind of efficacy is there. So stability of vulnerable coronary plaque, the size of vulnerable coronary plaque, and the perceptible stenosis at the site of vulnerable coronary plaque is there. Evolocumab significantly reduced the minimum peak density, reduced the demodeling index, and decreased the percentage of stenosis as well. And as it has been shown in previous discussion also, the clear data shows that evolocumab is more effective in patients with significant mitral infarction, so less than 12 months. So in fact, recently after these data have started, younger post-mitral infarction patients, in fact I give evolocumab on day one, and as early as we can give, and try and reduce the LDL to less than 50 or 50% of the baseline LDL value. So reduction of the key secondary endpoints, that is cardiovascular death, MI, and stroke with evolocumab is quite impressive. So if the patient has recent mitral infarction, you can clearly see that the 2 years cardiovascular event rates are significantly lower compared to the placebo. And again, if you see the primary and key secondary endpoints satisfied by the baseline background statin therapy, you can clearly see the odds ratio are heavily in favor of evolocumab compared to placebo. The evolocumab significantly reduced the risk of primary and key secondary endpoint in patients receiving maximum and submaximal potency statin therapy with no evidence of effect modification due to the background statin intensity. So the statin intensity is, statin is proven over the years, so we should continue that. But on top of that, if you add evolocumab, you need to gain more benefit. So evolocumab shows greater risk reduction when patients achieve LDL cholesterol less than 50 or less than 20 milligrams. As I said, in many cases, in our experience, we have been able to achieve as low as below 10, 20 milligrams deciliter, and can clearly see that, post-macular infarction, primary efficacy composite endpoint, cardiovascular death, MI or stroke or congenital vasculitis, all these things are directly in proportion to the LDL cholesterol level, which can sense the purpose that how strongly LDL cholesterol levels are related with the coronary event. So let's do a guideline-directed therapy earlier and lower. To start early, go aggressive. That is the way to combine. And LDL cholesterol, 70 milligrams per deciliter is not a goal, but trigger point to mandate more intensive lipid loading. Start communication in early phase after acute coronary event with patients, and to maximize the benefit and prevent recurrence of ischemic event, keep taking PCSK9 as long as possible. And we have seen, even now there are a lot of insurance agencies and the government agencies that have started, based on the evidence, approval for these patients to take this therapy. So in the end, I would say that this is a great therapy and has brought in, especially in patients in our country, it's very important that our patients are younger. Most of them would be myocardial infarction, and this is the kind of coronary disease patients who have got acute myocarditis and they are acute coronary syndrome patients, where the repeat event is significantly lower when you give PCSK9 inhibitor. And also, the other benefit which I have seen in our patients is that, many times the rebound surge in the lipid profile LDL is not as rapid and as malignant as it is when you stop the statin. So it is more a significant rebound phenomena. And the third thing which is very important is that other factors like lipoproteinuric A and all, they don't get decreased by any other molecule. No statin can decrease the lipoproteinuric A, which in Indian context, very, very important risk factor. But with PCSK9 inhibitors, lipoproteinuric A is also significantly lower. That is very important property of this molecule. And that's why it decreases the event rate significantly. So thank you very much for your kind attention. And at the end of the talk, I think we will have question and answer. So I think we'll invite Dr. Ripen Gupta now.
Yes, sir. You have to invite Dr. Ripen Gupta. Sir, you have to moderate the session.
Yes, you are my friend. Will you not help me?
I will help you, sir. Friends, after a wonderful presentation by Dr. Viveka sir, as I had promised, he lived up to the promise. We have the last presentation, and we will have the question answer session and the final word from Dr. Viveka Kumar sir. We have the last presentation from Dr. Ripen Gupta. Dr. Ripen Gupta has already been introduced. He is not new to the forum. Multiple presentations by him on the forum. And he will be speaking on post-PCI early optimization of lipid-lowering therapy in practice. Over to Dr. Ripen Gupta. Kindly give some take-home messages clearly so that we understand the importance of this new molecule. Dr. Ripen Gupta, over to you, sir.
Thank you, Dr. Sushil. I thank Dr. Viveka for giving me this opportunity. Basically, you see, initially when we talk of lipid lowering, our focus was only on statins. And as we have seen in the last two talks, now we have two other molecules which we consider. One is ezetimibe, though it is a very weak molecule and helps in modestly in reducing the LDL level. But the most potent agent is PCSK9 inhibitors. Initially, we were constrained by the cost and availability. Now it is available in India. Cost is still an issue. And as Dr. Viveka has very clearly emphasized, and Dr. Kubba also, that we should lower the LDL fast in high-risk patients. So let's go with that and see what the evidence is. So I'll be focusing on three things. One is the ACS event, what is the therapeutic focus, what is the data with PCSK9 inhibitors. Dr. Viveka has shared some data, I'll share some additional data. And also that what is the patient who receive this molecule during a MI or ACS, what are the levels which we can see and what are the benefits we will be able to see. So let's start with a simple case. There's a hypertensive diabetic male, chest pain with a troponin elevation, and he already had a PCI done twice. in the last 8 years. And ECG was showing a T-wave inversion in precordial leads, echo was okay. When we did an angiography, stents were patent, but now we had a new lesion in mid and distal LAD, calcified lesion, and PCI was done to LAD. Now LDL was 96 in this patient, and he is already on rosuvastatin 40, because this patient already has undergone a PCI twice, so maybe gradually we have increased the dose and now he's on maximum dose of statin. Now what to do? At 96, should we leave it like this? Because as Dr. Sameer has said, the guidelines say that we should go to around 70 in one guideline, 55 in another, and 40 is Indian guideline. So clearly what we know is that this is inadequate number. We should bring the level down. A second question comes that how to bring it down, and should we add just an ezetimibe? It will lower it modestly, but not to the level we want, around 40. Or straightway we go with the PCS9 injection, as Dr. Viveka has shown that he does this routinely in his cases, that patient comes with ACS and he has a high LDL level. We know we cannot achieve that goal with a statin, so we add a PCS9 injection along with the statin. So in this patient, what should we do? I'll present few slides and then we see. Now when a patient with ACS comes to us, in the early phase, the main focus is to decrease the ischemia. So what we do is if he is a STEMI, then we will do a primary PCI, or in a non-PCI capable center do a thrombolysis. If he has more ischemia, then we will do a cabbage, give him antiplatelets, anticoagulants, then order a lipid profile. Once we are through the acute phase, our now focus is the post-ACS phase, that is post-discharge phase. And here we will use the LDL values as we saw in our last case. This part of the LDL is not good, and we should do something more. And then we have to think of additional therapy. And the therapy which come to mind is adding a SMI or doing the PCS9 injection. And this has already been emphasized by Dr. Viveka that the risk of MI or recurrent cardiovascular events is highest in the first year, but maximum in the first 2 months of patient who comes with an ACS. So what we want is to have aggressive lipid loading. So this is a newer concept coming in, that if we give let's say we intensify the statin therapy or we add ezetimibe, it will take at least 3 to 4 months to achieve the target LDL goal. If we want a faster reduction in LDL, then we have to add another agent, and then we have to take use a PCS9 injection for that. And the data which has come in that only 50% of the patients who had a PCI get an LDL done in the next 6 months after angioplasty. So a lot of patients will not have a repeat LDL estimation done. Maybe they don't visit the doctor, or sometimes it is missed out. And out of the patients who undergo LDL estimation, more than 40% will have an LDL level of more than 70. So clearly, as Dr. Viveka has clearly told us, that if the LDL level is more than 70, the risk of ischemic events is more. And we can see here that the rate of MI depends on in the next 1 year, will depend on what is the LDL level. If the LDL level is kept less than 70, the risk is less, while if it is more than 100, the risk is higher. So clearly, number 2 factors come into mind. Number 1, all will not have the LDL estimation done after the discharge, so we don't know if they have reached the target or not. Secondly, it is difficult to achieve the target only based on statins and estimate. So clearly we should now start considering this third molecule also in our clinical practice. So emphasis that we should take it that lipid loading now constitutes 3 steps. 3 molecules. One is statin, second is ezetimibe, and third is PCS9 injection. If you look at the outcome data which Dr. Viveka has also presented, in the Fourier sub-analysis it was seen that patients who had a MI in the last 12 months or a multivessel coronary disease, they tend to have a greater reduction in events. Clearly, in the post-MI setting, the benefit of PCS9 injection is higher as compared to a placebo. And these patients in this trial, around more than 75 to 80% of the patients were already on high-intensity statin. So this is on top of high-intensity statin. When we say placebo, it doesn't mean that one patient was not taking any statin. So placebo and PCS9 group, both the groups were on high-intensity statins already in the background, and that was around tuned to around 80%. And on top of it, then when we added a PCS9 injection versus the placebo, we saw a significant benefit, and absolute reduction was something like 3.7% in the next 2 3 to 4 years. So that is very, very high number. 3.7% when we're talking of a total event rate of something like 17% is very high. And also we can see that patients, this is again something we have already presented, but we can again clearly see that over the period of time, if the patient has a prior PCI, the benefit rate PCSK9 inhibition is starts early and continues for next 3 years. And in a subgroup analysis of the same study, it was seen that besides lowering the LDL level, use of PCSK9 inhibition lower the risk of CABG surgery, complex PCI, complex revascularization, and it is a significant reduction. You can see that the blue line is placebo and the red is using a PCSK9 inhibition, and the reduction was like 24% for CABG, 33% for complex PCI, and complex revasc by 29%. So 1/3 reduction in events. So it is not like we are just lowering the LDL cholesterol. A lot of times it will come to our mind that okay, we are just reducing the LDL cholesterol and maybe we are reducing some hospitalization or some angina pain. No, we are reducing hard endpoints. We are reducing mortality, we are reducing CABG surgery, we are reducing complex PCI, complex revascularization in these patients over the next 3 years. Now, if you look at the data for PCS9 injection during hospitalization for an MIA-ACS, and Dr. Viveka has touched on this thing. So let's see one study which was done, EvoPack study. Here they gave patient giving the ACS, and in one group they gave statin and plus placebo. In one group they gave statin plus PCS9 injection, and they wanted to see the extent of LDL reduction over the next 8 weeks. And what we can see clearly is that baseline, this is the LDL level which was same in both the groups, and at week 4 and week 8 you can see that already there is a similar reduction in LDL cholesterol in both the groups, but it is more aggressive in PCS9 inhibition. And what we can see clearly is that this is constant. So within 4 weeks we achieve the goal, and this is maintained over the next another 4 weeks. And according to ACC/AHA guidelines, the European Society of Cardiology guidelines, more than 90% of the patients on statins plus PCS9 inhibition could achieve the goal, but only 37% of the patients according to ACC/AHA guidelines and 10% according to ESC guidelines could achieve the goal. And most of these patients were on around 40 mg of a torvastatin, which is a high intensity statin. So clearly this tells us that if we want an aggressive lipid lowering and we want to reduce the events in the next 1 year, then in our ACS very high risk patients, we should be initiating PCS9 inhibition along with the statin to give a better benefit. So what they are suggesting is that we should now switch from giving just a high intensity statin to high intensity statin plus the PCS9 inhibition to achieve a target dosage. So this is not tested for events. This is just a hypothesis generating trial, because it has shown that if we do this, we can achieve a very fast reduction in LDL levels. Now, how this pans out once we follow up these patients for the next 2-3 years, that study is still awaited. But with the data which Dr. Viveka presented and this study shows clearly a high rapid lowering of lipids in the acute setting. I think that is very, very important aspect which we should ensure. And if we see that lipid levels are such that they cannot be lowered with the high intensity statins, I think at least those patients should be offered PCS9 inhibition in the acute case. The case which I presented, now we are very clear. We are already giving a rosuvastatin 40 mg in this patient, and we are at LDL goal of 93. And we want something like less than 40 for this patient, because we already had undergone 3 interventions in the last 8 years. So this patient should ideally be receiving a PCS9 inhibition if we want to prevent long-term events in this patient. So to summarize, in a real-world study, we have seen that LDL levels after PCI have a definite relation with events. So higher the levels, more are the events. So there is an urgency to treat these patients, and recurrent events are very high after ACS. So ACS though stable angina now is not called a stable angina, it is a chronic coronary syndrome. But the events after that CCS are lower as compared to an ACS. So ACS puts the patient even at a higher risk of having events. And so we should be we should know that the patient comes to us with an ACS, most likely we will have a recurrent event in the next few years again. And we should always go for a guideline recommended lipid lowering. So we should adhere to the guidelines that we should have that target in mind. That okay, this is a high risk patient, very high risk patient, and this is the target LDL we should achieve. And we should go for early intensification of therapy, as Dr. Viveka has clearly told us that we should hit the LDL hard and fast, so that we achieve our goal within the next 4 to 8 weeks, and this patient then can be prevented or events can be prevented in the future. And in that, addition of a PCSK9 inhibition on background of high intensity statin, I think is a new solution for this, because otherwise, once we already reach the high intensity statins goal, then we know that going beyond that, we have to add something stronger than just LCMI. We can use LCMI in few selected cases. We should be giving it in when we have given exhausted high intensity statins. But we should also understand that what is the extent of lowering it can achieve. Beyond that, we have to take help of PCSK9 inhibition. Thank you. I'll hand over to Dr. Sushil Chauhan so that we can then.
Thank you, Dr. Ripen, for a wonderful presentation. I think all the 3 presentations were extremely good and informative for all of us. Dr. Viveka sir has left because of some emergency, and so we have our opening batsman and our great finisher in Dr. Ripen Gupta sir. And I will start the ball rolling, and then you can just keep on sending your questions. Very, very important topic, and since we know that for very long statins have been the backbone of lipid lowering therapy, and they have been affordable over a period of so many years now. Dr. Sameer sir, you are there? Dr. Sameer, you are there?
He is there.
Yes.
All right. So sir, if you permit, we'll start with you. Sir, you said that the new goal could be less than 20 milligram per deciliter. My question is, traditionally we've been using high dose statins, whether rosuvastatin in a dose of 40 milligram or atorvastatin in a dose of 80 milligram post PCI. Now, do you think that kind of a goal is impossible to achieve with statins, sir? And even if you add estimate to it, it's impossible to achieve a goal of less than 20 milligram.
So first and foremost, let me probably correct what I said. I did not say that we must target a goal of 20. So what I said is that if you have a very, very high risk patient, you may actually try to reduce the LDL to as low as possible, because it is relatively safe. The previous concern was you go very low, you may have stroke, you may have premature Alzheimer's, you may have cataracts, you may have high incidence of diabetes, and so on and so forth. But that has been laid to rest. So the point number 1 is low LDL or ultra low LDL is safe. We must not look at it that every patient must have an LDL of 20 or so. So the guidelines are very clear. You try to achieve less than 55 in very high risk patients, and any patient who has had an angioplasty or an MI, that means a documented atherosclerotic cardiovascular disease, basically becomes a very high risk candidate. But on top of it, like the kind of case which I showed you, and for that matter what Dr. Ripen was also discussing, is that you have had recurrent events, you have calcified coronaries, you have multiple risk factors. Probably an LDL of less than 55, maybe going to lower than 40 may also be beneficial. And as far as ACS is concerned, achieving low LDL is possible. That has been shown in EVOPACT and now in the Japanese study and many trials, and Dr. Viveka also was discussing his experience. Will it finally translate into clinical benefit? Nobody knows. But yes, there are high chances, and whatever we have seen with not only reduction in LDL but also reduction in lipoprotein A. And what statins do is they actually increase lipoprotein A, and what PCSK9 do is they decrease lipoprotein A. So the combination therapy is going to be the norm, like in all other metabolic disorders like hypertension or diabetes or antiplatelet therapy. Similarly, we are talking about combination therapy for dyslipidemia and trying to achieve ultra-low LDL levels for very, very high-risk individuals, not routinely. The Lipid Association of India, which I am also a part of, we have recommended for high-risk patients or very high-risk patients to go even less than 40. But if you go by international standards, still the value is 65. But very high-risk individuals, recurrent events, diabetes, multivessel disease, documented peripheral arterial disease, carotid arteries, stroke, and we find these kind of patients relatively commonly in our practice nowadays. So here in these kind of drugs may actually do the best.
Yeah. So can I just say one thing after a great answering by you, that lower the better, sir, as far as LDL is concerned?
Yeah, absolutely, yes. That's spot on. Thank you.
All right. Sir, you yourself mentioned that it's a costly therapy. And most of our ACS patients, they do not have the advantage of any panels or any reimbursement, especially 1 month from the discharge. So is it possible that we achieve a target of, let's say, 50 with high dose statin? And if you think that this patient is one who had multivessel disease and was of high risk category as you described, the various categories, what is the right time or what is the optimum time, apart from your advice, Dr. Viveka's advice, hit early, hit hard, but given the practical considerations in our country, what is an optimum or a practical time to start the PCSK9 inhibitors after you have given a good enough trial of high dose statin plus estimable? Answer this question, sir, because most of our colleagues will benefit from this.
Yeah, so that's a very, very practical question, and obviously, if you are able to afford a therapy and if you have tried a high dose of statin along with ezetimibe and the patient is tolerating that well and is not able to achieve an LDL goal, then possibly add an PCSK9 inhibitor. On the contrary, like the case which I discussed, who had a familial hypercholesterolemia, documented atherosclerotic disease, motivate them very, very strongly for PCSK9 inhibitors from the beginning. Unless and until you motivate them, they will never actually agree to it. Now the point is, which patient? So it's a costly therapy, you cannot give it to everybody. So try to exhaust your statin high dose and ezetimibe, and if it is tolerating it, fine. There would be a category of patients who may not tolerate it or may not achieve a very low level of LDL which you want. So in that case, obviously you are bound. But yes, there's another patient of mine who actually was referred to me by a cancer colleague who actually had an LDL of 389 and she was on 5 or 10 milligrams of rosuvastatin by some of her treating doctors, and she had FH, and I tried to convince her for a PCSK9. She did not have the finances, but with rosuvastatin 40 milligram and ezetimibe 10 milligram, I have been able to achieve an LDL around 70 in her. She also has a family history of strong premature family history of coronary disease. She cannot afford a PCSK9. But what I'm trying to tell you here is that it is just like smoke years or hypertension years or diabetic years, and Dr. Viveka in one of his slides mentioned lipid years. So the more you are exposed to this dyslipidemia for a longer period of time, this silently keeps on affecting your coronaries and peripheral vasculature and leads to recurrent events. So the earlier you do, the better it is, if the patient is able to afford it and if the patient is not having any side effects. But practically, it is not possible for every individual. We must give it a thought. And what I believe is with these kind of CMEs and discussions, at least they will be giving more respect to the lipid profile. We will be looking at lipid profile in greater detail and trying at least to use a high-dose statin and ezetimibe nicely, and then considering using a PCSK9 inhibitor in the relevant group of patients.
Thank you, sir, for wonderful answering. If there are more questions for you, I think we will ask you, sir. I will go to Dr. Ripen Gupta, sir. Dr. Ripen, you also brought home the points which were brought about by Dr. Sameer and Dr. Viveka, sir. Dr. Ripen, you are there?
Yeah, I am listening to you, sir.
All right, sir. What I want to know from you is, for the benefit of everyone, could you tell us the dose of PCSK9 inhibitors you use in your practice?
You see Repata is the brand name which is there from Dr. Reddy, and it is 140 mg injection, it is sub injection like the insulin injection, twice a month we have to give it. So it is 2 injections, that is around 24 injections in 1 year. So,
sir, this is once in 2 weeks then. This is every 15 days.
Once in 15 days, yeah, every 15 days.
It's once in 15 days. Now, sir, what I want to know from you is, suppose there is a patient who starts, with the Repata injection which you have advised, and after 6 months he runs out of budget. The problem with the injection is that there is a great rebound effect. You, I think, showed in one of the slides, or I think Dr. Sameer showed in one of the slides, the LDL was came down to 14 and then went back to LDL went back to 140. So how do you handle this? Is it possible that once you have achieved the target, aggressive target of LDL, is there a role for high dose statin for estimate, for aggressive lifestyle modification? After this, we tell the patient, now you see, it's a very costly therapy. Maybe then he will understand the role of aggressive lifestyle modification also. Your comment on that, sir?
Yeah. So my practice is very clear, Dr. Sushil. I always high intensity statins first, and once if they are not doing the complete job, then I'll add an azithromycin. And even if then we are beyond the goal, then we'll add a PCSK9 injection. But whenever I start this molecule, I tell the cost upfront to the patient, tell them they have to take it for a longer time. If they can afford, only then I start. I never start for 6 months or so. The patients whom I started, I told them they have to take it practically for life because we have exhausted all other avenues. And if they agree to the cost and to, more importantly, to take 2 injections every month, then only we will start that. Only one subgroup comes in mind, which is the hypothesis I presented. That patient comes to us, we give and he is high risk. Dr. Viveka also saying that in a ACS patient, we are trying to get the lipids lower, and patient is not already on a high intensity statin. We give a high intensity statin, give him 2 to 4 injections of Repata till the time the high intensity statins kick in, and then we can stop Repata. So that is a hypothetical situation. Some of us do it, some of us don't do it. In those situations, we can stop this injection. Ideally, we should not start this injection for 3 or 6 months in a patient where we know he cannot afford it. So that I am very, very clear that if I start this injection on a patient, I'll have 10 injection and everything, and then only start this injection. Because giving for 4 or 5 months is not of benefit in a long course unless we are talking of something like an ACS or a MI patient who is hospitalized. In a OPD stable patient, giving for 6 months is not of benefit because we want to lower the LDL for long term. Then only the benefit came. So giving it is of not much benefit. And I will re-emphasize again that given a proper dose, statins and high intensity statins and azithromycin does the job in around 70 to 80% of the cases. As Dr. Sameer also just told that patient had an LDL of 300 plus and he could bring it down only with the statin and azithromycin. We didn't have to use PCSK9. So clearly, a lot of patients can be managed. I think the take-home message which should go to all our colleagues is to start looking at LDL levels critically. Try to maximize the dose of statins. What I've seen is that adding this expensive molecule is beyond the scope of 99% of Indian patients. So, but for the 99% of the Indian patients who are there and high risk, at least giving a high intensity statin, adding the azithromycin, I think will do the job in most of the patients. But mostly what I've seen is that I've never seen a prescription of azithromycin coming in from my physician colleagues. So I think we have to start looking at LDL lowering, aggressive LDL lowering as a goal. So I think take-home message we should go clearly from this talk is that which Dr. Sameer, Dr. Viveka has clearly said that LDL less than 40 is okay. Number one. High intensity statins and azithromycin should be the bedrock of therapy. PCSK9 inhibition only in selected cases where we cannot achieve the goal with these two good molecules.
Sir, your points are well taken, but you know we have a habit of bargaining in India. Suppose one of my patients, I motivate him for Vipaka, and he says, doctor, can I take it once in a month? Is it better to take it once in a month than not to take it at all? Are there any India-specific studies, trials for this PCSK9 inhibitor molecule given the cost constraints in our country? Is it okay to take it once in a month?
You see, there is a once a month dose of Repata available in US. In India, we don't have that once in a month dose. So that is a higher dose, but it is given as a once a month. You see, we have to do the medicine according to the guidelines. So if we change the guidelines, because this medicine is tried in a huge subset of patients in European and countries, so the dose which is 140 mg twice a day. We cannot decrease the dose. So I'll recommend that if we cannot keep the patient as a financial constraint, then we should stick to statins and estimate lifestyle modifications rather than giving half a dose, because I think then we don't have the data for it.
Right, sir. So do you think we need some India-specific trials, India-specific studies?
You see, we need large outcome studies. If we try to do that kind of study in India, it is not possible because of the cost constraints. You see, we need thousands of patients, and with the amount of Repata used in India, nobody will be spending that much of money for India.
Right. Coming back to Dr. Sameer, sir, you mentioned about the coronary effects of LDL lowering, and you also mentioned while answering that there are advantages, of such as aggressive lipid lowering in the peripheral arterial disease. What I want to know is, are there any cranial benefits? Are there, as we say with statins, pleiotropic benefits? Those pleiotropic benefits are maintained with the LDL lowering with PCSK inhibitors. Are we having other benefits of LDL lowering like peripheral arterial disease, renal benefits, probably benefits on fatty liver, and stroke benefits? Your comment on that, sir?
Yeah, so anyways you reduce LDL, it translates into benefit. That is very, very clear. The statin therapy, the PCSK9, or whatever way you reduce LDL. So LDL is something which needs to be reduced. The maximum data is with statins, the maximum experience is with statins, and there are pleiotropic benefits which actually happen because ultimately it is the LDL reduction which is what we are looking at. And that is why if you look at guidelines, the guidelines look at an LDL value of say 55 or 40. The guidelines don't mention that you achieve LDL by this therapy or that therapy. So you achieve LDL by whatever therapy, you are going to translate that into benefit. And obviously, you have data for peripheral arterial disease, you have data for reduction in stroke, you have data for reduction in atheroma. If you look at this slide, there is a reduction in the atheroma volume, the plaque volume. So atherosclerosis is similar everywhere, except for some minute differences. You are able to reduce that unstable plaque, you can reduce that thick cap atheroma, and reduce those unstable lesions. So you will translate definitely into benefit. And very importantly,